Our first speaker is Dr. Mohan Ramchandani. It's a privilege that he belongs to Bhopal. He studied here, he worked here briefly before he embarked his journey into gastroenterology and later on joined Asian Institute of Gastroenterology, Hyderabad. Being his native city, he loves coming here whenever he gets a chance. And he's going to talk on acute pancreatitis, issues in management. Dr. Mohan.
Thank you, Dr. Vashne, and at the outset I thank Dr. Sanjay for giving me this opportunity, and my sincere regards to my teacher, Dr. H.H. Trivedi sir, Dr. Rajiv, and Dr. Loya sir. I think I was MBBS student when they were my teachers. At the outset I will say that it's a great opportunity for me to come back home, and I'll be speaking about acute pancreatitis. Yesterday we did more endoscopy. Let's talk about what is acute pancreatitis, and we have chosen some of the topics as a clinician, how a clinician will approach when a patient comes to you with acute pancreatitis. What are you supposed to do? So let's start with resuscitation. That is the most important aspect. So whenever a patient comes with acute pancreatitis, the first thing which we should do is start resuscitation, because there is very high third volume loss. So we have to resuscitate. The question is what fluid and how much. So let's see scientifically what should we give the patient. So early resuscitation improves tissue perfusion, and that is the key to success. And always crystallite solution should be the first line of treatment, no colloid. Now what fluid? So if you give large amount of normal saline which has got low pH, and it will cause hypercholeremic acidosis and AKI. So the best solution is ringer lactate, because it negatively regulates the toll-like receptors and cause more anti-inflammatory, and also the ringer lactate binds with calcium and it reduces inflammation. So the first choice is ringer lactate, and has been shown by many studies, and all of them have favored ringer lactate over normal saline. So the first thing is that always give ringer lactate. The second question is how much should we pour lot of fluid? So this was the very important randomized control trial in New England Journal of Medicine, which is known as waterfall trial. In this trial, they randomized patients into two groups, in which one group they gave aggressive resuscitation by ringer lactate around 20 ml per kg, say for example in 1 liter in 2 hours in a 50 kg patient. Now if you do so much of overload, what will happen? Whether it is beneficial versus those patients who benefited more, in which more calculated approach was taken. Let's see the results. So there was no significant difference between outcome. That is, those who are to develop severe pancreatitis develop irrespective of fluid. But what happened was aggressive fluid resuscitation was associated with significantly higher incidence of fluid overload than moderate fluid restriction. So the trial was halted because there was a safety concern. So the answer is, the finding of waterfall trial said that aggressive hydration is linked to worse outcome in critically ill patients. So no aggressive fluid, and that has been shown in many retrospective and prospective trials also. There is worse outcome with rapid fluid. So no rapid fluid. In fact, it should be goal directed. So the goal directed should be like give fluids so that you can achieve good urine output, you can maintain mean arterial pressure, central venous pressure and hematocrit. If this type of approach is there, that is better than just blindly, aggressively overloading the patient. What about the nutrition? Now the patient has come with acute pancreatitis, he is not eating. Whether you should start TPN or allow him to eat. The question is whether the TPN or eating. So it has been clearly shown that the early initiation of oral feeding reduces the risk of infectious complication, because there is gut barrier which gets disrupted if patient is fasting for too much. So there is translocation of gut bacteria into blood, leading to infection. But as soon as enteral nutrition is restored, this barrier is also restored. That means it is always better to start oral intake within 48 to 72 hours. And many randomized controlled trials have shown that TPN versus nasogastric feed or nasojejunal tube, the nasojejunal tube was associated with lower length of stay, less organ failure and less pancreatic infection. TPN is recommended only when enteral access is not possible. So always give oral. Oral significantly reduce mortality, multi-organ failure, systemic infection. That is why it is important to start oral feeding. Now patient is not able to eat, whether you put a Ryle's tube or you put nasojejunal tube. Nasojejunal tube is more cumbersome, difficult to place. Nasogastric tube is easy to place. So the trials have shown that there is no difference in mortality, infection complication and length of stay whether you put Ryle's tube or nasojejunal tube. So as soon as patient comes, you can start Ryle's tube feeding and that reduces the mortality. Now our aim always is start antibiotics. Now in acute pancreatitis, there are first place patient will have fever, have SIRS, systemic inflammatory response. That does not require antibiotic. So that is inflammatory. So initially inflammation and later on if there is a necrosis in the pancreas, which is not always common. You do a good CT scan after 3 to 4 days, you can quantify there is necrosis or not. Now to prevent, when there is an infection of this necrosis that happens in 3rd to 4th week, then that role of antibiotic comes. So the question is whether when the patient is in SIRS, systemic inflammatory response phase, can we start antibiotic and prevent infection of the necrosis? So prophylactic use of antibiotic is not recommended for acute pancreatitis without evidence of infection. In fact, you will do more harm if you start antibiotic prophylactically because you will produce more drug-resistant bacteria and fungal infection. Of course, if there is extra pancreatic infections like UTI, pneumonia, bloodstream infection, then that's a different issue. But do not start antibiotic just to prevent infection of the necrosis. Now, when there is acute ongoing inflammation, so there is a theoretical chance that can you start antiproteolytic enzymes which prevent the digestion of adjacent organ. This is a theoretical thing. So ultrastatin is one enzyme which is commercially available and is a trypsin inhibitor. Can we start in early phase of pancreatitis which prevent further damage? We have some results, but the trials are not that robust. But those have shown that in-hospital mortality was significantly lower in ultrastatin group versus the control group. But this theory is not very well accepted. In fact, China and Japan, they have done a lot of studies and shown that there is a direct dose-related reduction in mortality, but it is not widespreadly acknowledged that this drug acts at all. So as of now, we will not recommend to start such drugs. What happens in acute pancreatitis? Sometimes there is so much of necrosis and inflammation going on that there starts having intra-abdominal pressure increases. Now in early acute pancreatitis there can be high intra-abdominal pressure which is associated with very high mortality, and this is one of the indication of surgery in early phase of pancreatitis. In fact, I will say only apart from perforated bowel, this can be the only indication of surgery within 1 to 2 weeks of onset of pancreatitis. But there are certain medical things you can do like starts prokinetics, do some ascites drainage or vascular, do not overhydrate as I shown, but mostly if such situation arise, there is an emergency and Z4 pubic decompression laparotomy with laparostomy may be indicated. But this is very rare to happen now, but this can be one of the indication of surgery. Now, whether to ventilate patient or not, and non-invasive ventilation has been shown to prevent acute respiratory failure and to prevent endotracheal intubation. Why it happens? Because non-invasive ventilation restores lung volume by opening atelectic areas and increase alveolar ventilation, and it reduces the work of breathing. And in fact, in this retrospective study, those patients whom non-invasive ventilation was started, 54% of the patients were not intubated. That means that the early use of non-invasive ventilation, even in mild cases of acute pancreatitis, should be encouraged to prevent alveolar collapse, and it increase mean arterial airway pressure and ultimately may improve the outcomes. Now, this is now very early in the phase. We have started ventilation, we have done resuscitation, we are careful about antibiotics. Now, whether the patient is now deteriorating, whether we should drain the ascites or drain the necrosis and there is no wall formation. So the question is whether any radiological or endoscopic intervention early in the phase of pancreatitis helps or not. Now, it is well known that waiting is the most important because we want to make this necrosis walled off so that the drainage can be much safer. But in the phase when there is no walled off necrosis and patient is deteriorating, we have a window where the SIRS response has gone and some infection is setting in, but there is no wall formation. In these, the new data is coming that even early, less than 4 weeks of interventions performed may reduce the infection and organ failure and are associated with low mortality. And this was one of the paper published in American Journal of Gastroenterology recently, which said that if you intervene early, the infection rate and associated AKI and shock were significantly less if you intervene even in the early phase of pancreatitis. So the endoscopic intervention of pancreatic necrosis in 3rd to 4th week of illness appears to be effective and safe when a partial collection wall is present on cross-sectional imaging. And that is why one has the prior dictum of waiting for 4 weeks is gradually we are becoming more lenient. If the patients require, one can still intervene. Now there is chances that now the pancreas is necrosed, there is lack of pancreatic enzymes. Now can we start pancreatic enzymes from outside and will it improve the outcome? So as far as outcome of acute pancreatic necrosis or ultimate outcome is concerned, it has got no role. If patient has to die from acute pancreatitis complication, you cannot prevent by supplementing enzymes from outside. However, these enzyme supplementation leads to improvement of general course of the disease and health status. So one may think about starting pancreatic enzymes maybe at the discharge of patient, but it will not affect the ultimate outcome. Now those gastroenterologists who are working in a center where multidisciplinary approach is present, a patient with acute pancreatitis, especially gallstone pancreatitis with elevated ALT, AST, they are referred for ERCP. Now when to do ERCP? So in many surgical series, they have shown that patient with acute severe pancreatitis had stones impacted the ampulla, and early surgical decompression of this obstruction was associated with decreased mortality. But the real life scenario is that the gallstones are mostly passed off before you intervene, and it is unclear whether early ERCP will improve or not. So the present guidelines are the ERCP is not indicated in predicted mild pancreatitis, and it is not indicated, its ERCP is only indicated, I will say the only indicated in patients who have biliary pancreatitis and cholangitis, like pain, fever and jaundice. These are the patients who will benefit by urgent ERCP. Now what is urgent? Urgent is within 24 hours. Patient has come, he has cholangitis, he has pancreatitis, do ERCP within 24 hours. While patient who have documented CBD stone on ultrasound and he has acute pancreatitis, you may wait for 24 to 72 hours, and this is known as early ERCP. So that is how urgent ERCP only when there is pancreatitis and cholangitis. You can take help of EUS and MRCP. EUS is operator dependent, but it is very good. Even less than 5 millimeter stones can be picked up, and this can direct us whether ERCP should be done or not. I'll skip this. So now our patient is recovering. He has gallstone pancreatitis. We have done ERCP, biliary. Now whether to do cholecystectomy now or send patient home and bring him back after 4 to 6 weeks. So the answer was given by this Poncho trial. It said it randomly assigned patients who were asked to go home and come back for interval cholecystectomy versus those patients who are recovering from pancreatitis were asked to wait for some time and do cholecystectomy during same admission. The mortality and acute readmissions for complication was the primary endpoint, and in interval group, those patients who were sent home had more complications versus those patients who were asked to do cholecystectomy in the same sitting. So the same admission cholecystectomy reduces the rate of recurrent gallstone related complications, and that's how this Poncho trial helped us. I think I don't have much time. I will not go into the hypertriglyceridemia reduced acute pancreatitis 1, where there is a role of plasmapheresis, insulin infusion, heparin, hemofiltration, etc. I'll come back to the conclusion of my talk, and I will say that choice of fluid is ringer lactate better than normal saline. Aggressive fluid resuscitation is associated with worst outcome. Enteral feeding should be started as soon as possible. Nasojejunal feed is equal to Ryle's tube. TPN is recommended only when enteral access is not available. Prophylactic use of antibiotic is not recommended. Alnistatin type of drugs they may reduce, but we don't have good data. The early use of non-invasive ventilation, even in mild pancreatitis, helps. Intervention in the form of endoscopy or percutaneous drainage in 3rd to 4th week appears to be effective and safe. Enzyme supplementation may improve general course, but will not ultimate outcome is not affected. ERCP is indicated in patients with acute biliary pancreatitis and cholangitis. Cholecystectomy during index admission for mild biliary pancreatitis is indicated. Cholecystectomy should be delayed in patients who have persistent peripancreatic collections. And in hypertriglyceridemia, one should act fast because reduction of anti-triglyceride improves ultimate outcome. With this, I'll end my talk, and I'll thank you for patient hearing.
Thank you, Dr. Mohan, for an excellent presentation. I'll just kickstart the discussion. Majority of these patients who comes to us with acute pancreatitis, they have got bile attack. So, how to identify the patient who needs ICU care, who are going to be severe? One, when to subject this patient for CT, early CT versus delayed?
I think I'll answer the second question. The CT done, so there are dictums, there are rules for CT scan. Like a patient who comes with acute abdomen, they do not have the label of pancreatitis, and you are not able to diagnose whether it's pancreatitis or not. If that is the question, then it should be done immediately to see for what is the cause. But if that question is whether the pancreatitis is necrotic or interstitial pancreatitis, because the prognosis changed completely, then it should be done 3 days later, because necrosis takes time to set in, and that can be picked up by a CT scan. But if there is a hemorrhage and if there is a pseudoaneurysm, other answers can also be given by CT scan, which can be done as soon as the symptom arise. Regarding prediction of severe pancreatitis, there are many criteria, ransom criteria. I have not enumerated that. But I don't think anything is available bedside which can tell us that, okay, this patient will have. We take a lot of help from CRP and other things, but practicality is much less, I agree.
Can we make a generalization, because there are plenty of criteria, a lot of confusion, lot of diagnostic prognostic scoring systems. So SIRS persisting for more than 48 hours and a patient with organ failure. if it is persisting for more than 2 days, so these are the patient who needs ICU care, they are high risk patient.
So basically for the physician as a bedside, when patient comes to their OPD or to the emergency, there's a revised Atlanta classification, mild, moderate, severe. No organ failure, you can keep the patient with you. Patient has an organ failure, recover within 24 to 48 hours with the fluid resuscitation. The patient has a moderately, he may stay there or can refer to a tertiary care center. With the organ failure persisting for more than 48 hours in spite of fluid resuscitation, it is always better to refer the patient to the higher center within ICU facilities. I think that is important for the physician to know. That is a revised Atlanta classification, and that is going to talk that how you should manage. And regarding the CT also, generally you should avoid CT scan unless until there is a doubt. You do CT scan after 3 to 4 days, and now the concept is you do CT even after a week when patient develop the fever, when the second week patient has a chances of the infection getting in. So either do a CT scan after 3 to 4 days when the necrosis has set in. This is a common practice. Patient come with a CT scan, mild peripancreatic inflammation, and he says my patient is in the ICU on ventilator on dialysis. And CT scan is not, because it is done within 24 hours and it doesn't show the changes of severe pancreatitis. So the message is doing early CT scan, produce renal failure, delay the CT scan. The only CT scan to be done in early phase if the diagnosis is in the doubt, as Mohan said. And that's true also, you do a plain CT scan first. If no pancreatitis, then you can do a CT angio to rule out a mesenteric ischemia. That should be followed.
Mohan, I am a surgeon. So my question is, between the endoscopic drainage and a percutaneous radiological guided drainage, which one is better?
I think whenever we have a necrosis around the bowel, like say for GastroCare, endoscopy is much better than percutaneous because associated with less external pancreatic fistula. But all necrotic areas are not accessible by endoscopy, especially parabolic cutters and other things, which can be managed by percutaneous drainage. So we do step-up approach using percutaneous drainage, endoscopic drainage, and then if this problem still persisting, we follow up.
Yeah, because you do an early drainage because these patients are in systemic failure. You are not doing it therapeutically. You are optimizing the patient. And these patients, the main aim is you want to reduce the sepsis or the SIRS. If you do endoscopic, you don't have any control over, you can't control the drainage. You can't flush it. You can't suck it. That's the biggest problem. The necrosis, see, necrosis is a sponge. It's never a hard tissue. And this sponge absorbs so much of pus that unless you suck it hard, you will never get the fluid out. The SIRS, you can always reduce the SIRS only by sucking it morning and evening, and you will be surprised that radiology says volume 200 ml of the necrosis, and you are still sucking out 150 mils of pus every day.
So sir, question is not percutaneous and endoscopic, it will depend upon the duration. If less than 4 weeks, the wall is not formed, and if patient in the sepsis, you do a percutaneous drainage. If the wall is formed, periluminal, more than 4 weeks, you do endoscopy.
That's
it
what
is not
I
the
was
matter
saying.
of the importance of is the wall has formed or not. Because we are talking about the minimally invasive surgery. Either it is endoscopic or percutaneous, it will decide about the duration and the location of the collection. If the duration less than 4 weeks, and away from the bowel, irrespective of that, you have to do the percutaneous drainage. And if it is in the surrounding the bowel more than 4 weeks and the wall has formed, then endoscopy is minimally invasive and you can send the patient within 2 to 3 days. That is a concept behind doing the percutaneous versus endoscopy.
That's what I was saying. Percutaneous for optimizing and taking him out of SIRS. By doing an endoscopic after 4 weeks, these patients are in low SIRS, smoldering pancreatitis. They are never in full-blown
I will
SIRS.
say, sir, after 4 weeks also, if patient has the infection, he may not be in the smoldering phase. He can came back with again the SIRS response. So it will depend on the presence of the infection, how
Yes.
the patient is behaving.
So in 2 to 3 weeks, percutaneous is always better than endoscopy.
If I can interrupt, I mean, we are running late, so can we discuss later on at the time of lunch?
Thank you, Mohan. Very vast topic, I know, and time limitations are there. You have summarized very nicely. Thank you.